Good afternoon, everyone, and welcome to the annual seminar of the EuroHealthNet Partnership for Health Equity and Wellbeing. It's so nice to see so many of you here in the room. And we also had more than 600 registrations online. So a special thanks also for our online participants. I'm particularly excited to be here. Caroline Costongs is my name. I'm the director of EuroHealthNet, and I'm also Dutch. Even though I'm based, EuroHealthNet is based in Brussels, and I'm in Brussels for more than 20 years. But the Netherlands, of course, is very important to me, and therefore it's very special for me to be here in Jaarbeurs and in Utrecht. And a big thanks in particular for our very important members of EuroHealthNet, RIVM, the Dutch National Institute for Public Health and the Environment, and also the Trimbos Mental Health Institute. They are hosting this event, and they are in fact hosting the whole General Council over the couple of the next 2 days, and also co-organizing this seminar together with us. We have invited some excellent speakers and some fantastic moderators. We even have thought of 2 exercises that we will use during our 2 sessions to make you move up and down from your chairs. And I hope that we will have a great seminar. The purpose of the seminar is to discuss together how can we ensure health and well-being for everyone. We are living in quite some turbulent times. Also at the European level, as you know, we have the elections, European elections coming up later this week. So it's quite important to see how can we make sure that policymakers remain a strong focus on public health, health equity, health promotion, disease prevention, and what evidence-based advice can we give to those policymakers and those new elected policymakers as well. What new insights do we have in the area of mental health, well-being, in the area of health behaviors and the way we live, and how can we reduce health inequalities? So that's the purpose for today. And without further ado, I'm delighted to introduce to you Marith Volp. She's the Director of Public Health and Health Services at RIVM, and I'm happy to give the floor to you, Marith.
First of all, a welcome to you all, live here and online participants, esteemed colleagues, distinguished guests. In times of change, strong institutions, including public health institutions, are essential for sustainable economic growth, social stability, and overall well-being. They are deeply embedded in a country's social context and require continuous adaptation to meet evolving challenges. The COVID-19 pandemic has underscored the importance of robust public health institutions in crisis response and recovery, and I'm quite certain that we will remain significant if we continue to adapt to challenges. EuroHealthNet is dedicated to supporting healthier, more inclusive, and sustainable societies. This mission aligns closely to the goals of the Dutch Public Health Institute, the RIVM. As we pursue these objectives, let us recognize that every action matters, whether it involves supporting local initiatives, national programs, or advocating for international policy changes, as EuroHealthNet does. What also matters very much to me personally, especially in these turbulent times, is the need to reach out to each other and repower multi-sectoral collaboration, or what we also call it, health in all policies. As a former general practitioner in a deprived part of Amsterdam, I stood at the intersection of health and community, and I witnessed how health is intricately woven into the fabric of our societies. I witnessed how health is, on a daily basis, for my patients, not solely the domain of clinics and hospitals, but is very much influenced by myriad factors beyond medicine: education, housing, social relationships, behavioral coping mechanisms, and many other factors beyond medicine are leading determinants of the health of my former patients. So, to truly impact our population's well-being, we must transcend traditional healthcare boundaries and bridge gaps between ministries. Today, as we will be discussing mental well-being and health behavior, I invite you all to go beyond traditional boundaries to navigate complex health challenges. By working together across sectors, disciplines, and ideologies, we can build healthier communities. It is a slow, gradual process, one partnership at a time, but an immensely relevant one, and you all know this. In closing, I would like to thank you for your dedication to public health. I hope this annual meeting will inspire you all, EuroHealthNet members, to keep following our course towards a healthier and more equitable future. I believe that together we can drive positive change, even in times of uncertainty. Thank you very much.
Many thanks, Marith, for your nice welcome words. And now it's my pleasure to invite to the stage Marjolijn Sonnema. She's the Director General for Public Health at the Dutch Ministry of Health, Welfare and Sports. The floor is yours.
Thank you very much. Well, on behalf of the Ministry of Health, Welfare and Sports, it's my pleasure to welcome you to this EuroHealthNet Seminar, Annual Seminar. And it's great to see so many people here in the room and even more online. Well, one of the topics you're talking about today is mental health. And I don't have to tell you how important that is. You know much more about it than I take it. Instead, I'd like to briefly explain some of the ways we promote good mental health in the Netherlands. More and more people here in the Netherlands are facing mental health issues, like everywhere in Europe. And whether they arise from work stress, pressure to perform, debt, or worries about the future, mental health problems always have a big impact on people's lives. So how can we help people to cope better and to make sure that they can continue to play an active role in society while we need them? These were the questions we had in mind in 2022 when the Netherlands kicked off a national action plan named Good Mental Health for All. And the aim of the plan was to start a broad social movement in the Netherlands with a focus on mental health. All of us have a role to play, be it employers, healthcare professionals, schools, sport clubs, cultural and social organizations, government bodies, and ordinary people, of course, too. In the plan, we focused on 5 aspects of life where it's especially important to pay attention to mental health. Society in general, people's neighborhoods, education, work, and people's online lives. And we want to get people talking about mental health and prevent mental health problems, or at least recognize them promptly. And we also give people information they can use either to improve their own mental health or to help others. For instance, there are inspirational meetings for regional and local policymakers whose work concern the mental health of people living in their areas. And these are opportunities to share knowledge, examples, and practical tips on how to create a local and regional policy that benefits maximum to public health, to mental health. And in a sense, you could say, as we are here together, we are doing the same, but they're not on a local and regional level, but more on a European level. Young people in particular are often struggling with issues like stress, loneliness, and lack of motivation. And the COVID pandemic hasn't been doing good to that. In fact, in the Netherlands, 37% of the young people report problems like these, compared to 21% of the adults. And if we do not help these young people, the problems will persist throughout their lives. And that's why young people are the special focus of our national approach to mental health. Children and young people develop best, learn most, when they feel well. And so schools need to be safe, comfortable environments where they can develop socially and emotionally. Professionals who work in education and healthcare and those who design policy can create an environment like these. And to help them, there is a program called Wellbeing at School, and it offers scientifically sound information and practical resources for improving the well-being of the pupils. But of course, school isn't the only thing that can influence young people's well-being. There are also the people they know at their sports clubs, at their part-time jobs, or around their neighborhoods. In other words, there are various places where young people meet others who might be able to provide some kind of support and mental health. Mind Us is an organization in the Netherlands that focuses on youth and mental health. It has developed a digital program to support people who interact with young people on a regular basis, like trainers at football clubs, managers at shops that employ young people, and many more. The program gives them information on how to tell when someone is having problems, so to detect, and how to start a conversation about that, and what they can do to help. Well, this was a very brief introduction in the time I was given to speak to you, to tell something about how we try to help here in the Netherlands people with mental health issues. Today you will hear from a range of experts on how best to support all these people, especially the young people. And I'm sure that you will learn that what you learn will help you to improve your policies further, whether that's here in the Netherlands or in your own countries. Let's learn from one another so that we can together help to create healthy societies with healthy mental people. So I wish you a very enjoyable and enlightening afternoon. Thank you so much.
Many thanks, Marjolijn, for your inspiring words and for setting out the Dutch mental health approach. We have also asked the Nicolas Schmit, the European Commissioner for Jobs and Social Rights. I'm pretty sure that most of you haven't heard of Nicolas Schmit before, but he's actually quite important at the European Union level. And we asked him his views about mental health and what the European Commission is doing about mental health. So if you can show the video, David.
Ladies and gentlemen, I'm grateful for the opportunity to address the issue of mental health at your annual seminar. I'm glad that the issue of mental health has gained traction under this Commission's mandate. It is increasingly part of a broader conversation about public health. We need now to push this topic even further, recognizing the strong link between mental health care and our aspiration to achieve true social equality. Therefore, I am particularly sensitive to the issue of access to health care and to mental health at the workplace. It is clear that the world of work has changed immensely during the recent decades. Digitalization brings more flexibility on when, where, and how work can be done, but it can also increase work intensity, blurring the boundaries between work and private life. Moreover, we live in turbulent times due to climate change, the recent pandemic, the ongoing wars very close to our borders. All of this affects EU citizens and workers' mental health. Some population groups have been affected more than others. Young people, essential workers, farmers, and mothers with young children, to name a few. The EU takes this issue very seriously. Last year, the Commission adopted a communication on a comprehensive approach to mental health. It included 20 flagship initiatives and identified 1.2 billion euro in funding. The communication recognizes that mental health is a fundamental aspect of human well-being. Everyone has the right to timely access to affordable, preventive, and curative care of good quality. This is one of the principles of the European Pillar of Social Rights. We are collaborating with the member states on how to tackle psychosocial risks at work. On this basis, the next Commission will be equipped to decide on a potential legislative proposal specifically targeting this issue. On a broader level, the Commission is supporting member states in putting in place policies and programs for the lifelong prevention of non-communicable diseases. This is very important, as these diseases are responsible for 80% of the total health burden in the EU. EU OSHA, our agency in Bilbao, is also running awareness campaigns that help bring attention to mental health at work. Mental health support in the workplace isn't just about being kind to each other. It's also about creating healthy and productive companies. Common action is key, and this is exactly what you are doing in this seminar. I wish you good health and a successful seminar.
Many thanks to Commissioner Nicolas Schmit. It's great to see how mental health is taking forward at the European Commission level, and I hope you heard that they are indeed working to explore whether there is legislative action possible to ensure mental health at the workplace by, in a way, making sure that employers try to reduce psychosocial factors at work. So I find this quite exciting and it's quite promising. As we are on the topic of mental health, I think it's a great introduction now for the session, the first session of our seminar. And I'm very pleased to hand over the moderation to two moderators. First of all, we have Nicoline Tamswa. She's the coordinator advisor of RIVM and also one of the former presidents of EuroHealthNet. And the co-moderator is Matej Vinko. He's the head of the Mental Health Center at NIGZ, which is the National Institute of Public Health in Slovenia. Nicoline, the floor is yours.
Thank you, Caroline. Just to say, it's really nice to be back in the family of EuroHealthNet after 6 years. That's great. So this is going to be a team effort. Matej and myself are going to try and moderate the session. But I was given the wonderful task to introduce the session very briefly. Of course, everything's going to be very brief, succinct, and on the point. So it's Commissioner Schmit, who is the Commissioner for Social Affairs. So this is also why he talks so much about the social determinants, quite rightly. As he already mentioned, mental health really is a fundamental aspect of human well-being. And it has gained traction. There's more awareness, been more action, it's more politically on the agenda. We've seen this at EU level, but also at Dutch level, as our DG Sonnema has already explained to you a bit. So Commissioner Schmit also reminded us that some population groups are much more vulnerable to mental ill health than others. And that we live in turbulent times, as I do not need to explain to you again. Times that follow a very unprecedented pandemic as well. So again, that pandemic impacted on similarly vulnerable groups, and usually the same ones. Our mental health already was a problem before the pandemic. And we know the pandemic exacerbated poor mental health. And just let me share a mini reminder of how that works out, for instance, on the young people in the Netherlands. Only last week, RIVM, together with the association and the local health authorities in the Netherlands, published their youth monitor. This is a monitor of 188,000 young kids in year 11 and 9 of our secondary schools, asking them about various things, including mental health, happiness and stress levels. So we did this in 2015, in 2019, and then we did an additional one because of COVID in 2021. And so again, we did it in 2023. And what we found out actually is that after COVID, of course, due to COVID in 2018, stress levels went up, but they haven't actually gone down yet. They actually increased. The same with happiness. Happiness is stable. It went down as a course of the pandemic, during pandemic times, and it's not actually gone up again. So we can't turn that page. So if you want more details on this, you can go to our English web pages, which we boosted especially for the occasion. But let's go back to mental health and our wonderful speakers. This is a EuroHealthNet seminar, not just any seminar. That means that we're looking at a bit more of a deep dive into social determinants of health and mental health, inequalities and how we might tackle them, looking at the impact on people that might be already vulnerable. So what drives mental health? Or mental health problems, for that matter? What policies might work? And how can we deliver good results? How can we make sure policymakers work together from different silos? And what role can international organizations play, including EuroHealthNet? So these are the things that we will be addressing in this part of the seminar. And we have great speakers lined up. So Matej will introduce them to you, and I wish you lots of inspiration.
Thank you. Thanks, Nicolas, for setting the stage. So I'll provide the technical answer of how we're going to answer the questions that Nicolas posed. We'll have two stages. First, we're going to have presentations from our experts here in person. And afterwards, we're going to have a panel discussion, of course, with questions from the audience. Now, your participation in this session is crucial for the success. So do keep in mind and prepare your questions while the presentations are ongoing. Now, to keep in line with the theme of this session, brief, succinct, and to the point, we'll start with our first speaker, Professor Laura Shields-Zeeman, Head of Mental Health and Prevention at the Trimbos-Institute, and a professor at Utrecht University. Professor Shields-Zeeman will provide a global perspective on factors influencing mental health. Professor, the floor is yours.
Thanks very much, Matej. It's great to be here today with everyone, also here online and in person. I don't have slides, so that means you're stuck listening to my voice and looking at my lovely co-speakers today. Let me start with some good news. Mental health is getting more attention than ever before, and this is evident in our public discourse as well as in our policy decisions, and this is happening in many countries. And I think the focus is not only due to the hard work of many advocates, researchers, policymakers, but also because of the number of complex societal challenges and crises that have unfortunately pushed us to focus more on mental health. Now, there's been a lot of good things happening in the last few years, as you've heard in the previous talks, but how do we move from celebrating this attention to sustained action? And how do we actually ensure that our systems of different kinds keep us well and provide us also with timely support when we need it? If you came here expecting a simple solution to mental health, I'm going to have to disappoint you because there is no quick fix. Mental health is complex, and that's because it relates not only to how we feel about ourselves, but also how we relate to others, and it's shaped by the worlds around us. Everything from our income levels to where we live, to the laws and policies that shape our daily lives. So it's a combination of individual, social, and structural factors that shape our mental health. And for anyone who wants an overview from the scientific literature on these different factors, please come find me in the break or during the reception. And mental health isn't a static state, it's dynamic. It changes and responds to the changes in our lives and responds to the things happening around us. Now, these factors that I just mentioned, individual, social, and structural, can either protect our mental health by giving us, for instance, psychological buffers to manage stress better, and risk factors, especially the ones happening in developmentally sensitive periods in our lives, can put us at greater risk of developing mental health problems or exacerbating existing mental health problems. So think of protective factors like a supportive social network around you or a stable, fulfilling job, and risk factors as examples like bullying, experienced work discrimination, or a longer period of financial problems. Now, these factors affect each person and each community in different combinations and degrees across the lifespan. We also know from research that there's a lot of relationships between these factors as well, so it's unlikely that addressing one factor at a time to improve mental health is going to be sufficient to affect outcomes at a population level. Note that I've said a few times that mental health is complex, but I didn't say that it was impossible or intangible. Now, mental health doesn't discriminate, but our societies do. Some people, as we know, are more likely to experience mental health challenges than others, and some people are more likely to experience good mental health than others. And these differences aren't fair, and they're not random, and they're distributed and shaped by power, resources, and money in our countries. It's a bit older data, but from 2019, there was a WHO report which stated that 76% of the differences in our mental health is due to living conditions, social protection, and income. And that's only for the European region. So what can you do to advance population health? Today, I want to share with you two things that I think we could do more of: creating and sustaining public health policies that can really impact mental health outcomes, and creating living environments that keep us well from a mental health perspective. As you're going to hear today, mental health is, of course, influenced by policy decisions that take place outside of the healthcare domain, so education, employment, climate, social protection as examples. And we know that good mental health also has benefits for other domains like educational attainment or social cohesion. In the interest of time, I'd like to single out one area of policies as an example, and that's income policies. A recent systematic review and meta-analysis actually found that 88.9% of policies looked at that focus on income from around the world had beneficial impacts on mental health outcomes. And these effects were comparable with individual level interventions like therapies or antidepressant prescriptions. This same review found that taking away income supports had even a bigger effect on mental health, but in a detrimental way. We've also seen this in our own data. For example, from the Nemesis longitudinal study at Trimbos, those who had financial troubles had 4 to 5 odds higher of having depression or anxiety than those who did not. My point is that policies in other sectors have a significant impact on mental health, and we need to do better at making these impacts explicit, and to do more evaluations like the review that I just mentioned to understand whether and how these types of policies in other domains have an impact on mental health. Now, you've heard mental health in all policies, and there's a lot of attention towards this term now, which I think is really important. But I think the next step is to move to how do we take this policy framing and actually implement it in our different countries, regionally and nationally. There's a few points that I think are important here. One is that we need to measure the mental health impacts of policies in other domains. Sometimes this can mean just taking a mental health measure and including that in the evaluation of a policy in another sector. Taking a local example, in 4 cities here in the Netherlands at the moment, there is experiments going on either to pay off debt or to provide basic income to citizens. And we may not immediately link this to mental health outcomes, but research internationally has shown that cash transfers and income support policies affect mental health outcomes like autonomy, anxiety, and reduced distress. And these city examples in the Netherlands are actually including mental health measures. So this is going to be really interesting to see what comes out of that. Sorry, too many papers here. Second is I think that it's important to support policymakers in formulating clear goals, which can be actually evaluated, and to give a clear overview of what the trade-offs are when making policy that relates to mental health outcomes. That's not always so explicit. 3, to understand how implementation of measures and interventions in different settings impacts outcomes. And 4, it's not just enough to make policies and to do evaluations, but we need to also embed the lived experience of how these policies impact people's daily lives. Now, the second strategy is healthy environments, and this is a room full of health promotion experts, so I don't need to explain how environments are important of shaping mental health, where we study, play, work, get care, etc. So when I think of creating environments, so think of schools, workplaces, or neighborhoods in the case of mental health, we need to make sure that there's an integrated mix of policy measures, interventions, and supports that combine universal, selected, and indicated interventions that can support each other. This sounds like a lot, and it is, but what we don't need is more interventions and more new measures in an already very fragmented landscape. So for example, in the Netherlands, we have 334 interventions for youth well-being. It's a lot. We need to focus more on strengthening what's already there, on looking at common elements across effective measures and interventions, and on implementation, rather than focusing on introducing a 335th intervention. Now, within that environment, what could that actually look like? So let's take the neighborhood as an example. I would see that as having social meeting places, a mix of social and cultural activities that bring people together to connect, build trust, and reduce social isolation and loneliness. I will skip what I think is very important. We can have a discussion, the discussion part. Early home life visits for prenatal and postnatal support. We know that's effective in improving outcomes of women, but also of children later in life. Local policy measures that help people get financial support when they need it. And here we know it's not just about access to financial support, but also the red tape and bureaucracy to access that. And sometimes that can actually outweigh the mental health benefits of the income support in the first place. And centers that combine physical, mental, and social care support in the same place. That's also really important. And we've seen that through our interviews with stakeholders, that it's really important to bring these silos of professionals together under one roof. I think the bottom line of the living environments is that when we actually sustain and create these environments that promote mental health, we're not just focusing on the individual outcomes, but we're also focusing on the broader social and economic context, which ultimately can have an impact in reducing mental health inequalities. I think this all feels very daunting, seeing the political developments in our countries, but I think we're at a point of no return when it comes to attention for mental health. And I think going forward, 2 things are important to discuss. One is that we need to work together more. We need to streamline the chain of support and action from mental health promotion to prevention to treatment to recovery. And we need to do that within the health sector, but also outside of the health sector. We often feel like we're working against each other, but we're part of the same team. And finally, we need a clear vision for how we want our societies look like and how mental health fits into that. That means uniting with stakeholders that we don't normally have day-to-day work with, listening to others who don't share our opinions, and finding common ground into how to improve mental health for all.
Thank you, Professor Shields-Zeeman. I'm sure you're going to have a bunch of people surrounding you during the coffee break, since you skipped the most important part for the coffee break. We'll continue with a presentation from Jessica Mahoney, a policy analyst at the OECD Center on Wellbeing, Inclusion, Sustainability, and Equal Opportunity. Jessica's work focuses on how policies can be designed to both support mental health and broader aspects of well-being. Jessica, the floor is yours.
Thanks so much. I'm a bit shorter, so let me adjust this more appropriately. Thank you so much, EuroHealthNet, for having me here. It's a real honor to get to share our work. This is also my first time in the Netherlands, so it's very exciting. So my name is Jessica Mahoney, and I am a policy analyst at the OECD's WISE Center. WISE is an acronym for Wellbeing, Inclusion, Sustainability, and Equal Opportunity. And so today I'd just like to briefly overview some of the work that we've done on a project that looks at the interactions between mental health and our broader well-being. That work culminated in a report that was published late last year of the same name of my presentation today, which is How to Make Societies Thrive. So our report is looking at the ways that mental health interacts with and is related to all of the other aspects of our lives. And importantly, what this means then in terms of engaging with stakeholders outside of the health sector when we want to promote good mental health in policy. And what you see on this slide behind me, which is related to a lot of what Laura just told us, is that people with worse mental health outcomes compared to the general population tend to fare worse across all other aspects of their lives. So yes, this is true of physical health. Yes, this is true of a lot of different material conditions, but it's also true of civic, environmental, and relational outcomes. So because mental health then intersects with wider well-being in so many different ways, this means then that policymakers really have a clear opportunity to design programs and interventions that can simultaneously benefit our mental health and benefit other aspects of well-being. So you can think of this as a so-called win-win policy. And the important thing is that a lot of these policies go beyond just the healthcare sector, and sometimes they might even be led by agencies that are not specific to the healthcare sector. And so there are sort of a list of examples behind me. There's even more in the report. But what we do is sort of in systematically going through all of these aspects of well-being and looking at how they relate to mental health, you uncover a series of different policies. So sometimes these are relatively well-established pathways. One such example might be increasing access to social assistance programs. We heard a bit about this. Debt relief initiatives and maternity leave benefits. These have been shown in a number of different studies to have explicit mental health benefits. Another avenue is decreasing the cognitive burden of enrollment to these programs, so systematically scanning services for psychological barriers that might make it harder for different kinds of service users, especially those, for example, who are experiencing mental ill health, to engage with the service system in the first place. But by systematically going through all these different aspects of well-being, we also sort of uncover more recent policy innovations. So one such example is to expand social prescribing efforts. So these are programs where healthcare professionals connect patients to non-health related support, often provided by community organizations. And that can take a variety of different forms, but examples might include debt advice or financial planning workshops, time spent in nature or arts and sports activities. There's a lot of evidence suggesting that this can improve social connectedness. It improves both mental and physical health, but it also can save costs in healthcare because it's a preventative action. Beyond just providing personalized non-medical care, it can also channel funds into third sector organizations. Other novel approaches might include different ways of approaching environmental accounting and cost-benefit analyses that can better take into account the significant direct and also indirect costs, mental health costs that is, of climate change, and also some of the benefits of climate action. So doing this exercise, we come up with a very long list of policy solutions, and some of them look great, but it's a very long list. There's sort of not a priority setting. And of course, we also know that implementation of these types of policies doesn't just happen in a vacuum. So it needs to be supported by broader systems that are going to provide the resources, incentives, and arrangements that enable these to be created in the first place. So we've already heard mental health in all policies, right? Calls for mental health in all policies are nothing new. And anyone who works in this field, though, and I think almost everyone in this room does, knows that in practice, actual coalition building with other sectors outside of health still remains relatively limited, and it's often not implemented at scale. Some of the big challenges associated with this often include the fact that these interdepartmental task forces are time limited, so it's just sort of a one-off thing. They don't always have decision-making power. Aspects like accountability or actual plans for monitoring and evaluation of partnerships aren't written into these high-level strategy documents, and it doesn't make it clear and explicit. And then, of course, fundamentally, resource constraints, this is always a problem. So in thinking about this, not to solve the problem, but in thinking about this, our report really wants to understand, okay, so what then are some of the ecosystems that can support the implementation of these types of collaborative approaches in practice? And so we explore this question by looking at 9 different case studies. So these are just examples across OECD countries. So it's by no means an exhaustive list. And for each of these initiatives, which you see up here on the slide, we want to understand how they're set up in ways that might align across departments and also levels of government, that redesign policy content to take a broader view to encompass the upstream determinants of mental health, that refocus on the promotion of positive mental health, so going beyond just prevention of ill health, and then finally that are connecting with a wider range of stakeholders, whatever that might mean, including people with lived experience, young people, civil society, and research. So lessons of what works in each area and what this looks like practically in each country, including sort of specific examples, are in the report. But there's sort of a few cross-cutting themes that I'll spend just a little bit of time to emphasize here. So the first is that explicitly defining mental health goals can really help different agencies and stakeholders to focus their actions. So understanding what precisely are we trying to do? What is the outcome we're trying to improve? Who can contribute to it and what is their job? So how do you kind of go about setting up structures to do that? There are different ways, different approaches. So one can be using a multidimensional framework to inform mental health plans and to explicitly point out these links to other sectors. Another way is to formulate concrete implementation plans or ensuring that that's written in from the start of a strategy. The second important point is that collaboration. So if that's partnership building, knowledge brokering, whatever it may be. If you're doing this, horizontally between different government agencies or different levels of government, or if you're supporting community actors, whatever it is, it takes resources. And importantly, resources doesn't just mean money, it also means time. So in several of our case studies, there was a conscious move away from short-term project cycles and extending to longer project cycles. I think the longest was even 12 years, but at least multi-year processes that allow relationships to form. You have management capacity that's able to be built, and it also allows for some space for program design experimentation. The third point is that strategic grant making by public health agencies, especially at the local level, can be a promising way to allocate funds for activities that target mental health determinants upstreams. And we see that, practically speaking, in a number of these countries, it results in things being funded that traditionally hadn't been under the remit of the healthcare sector. And then the last thing, and I think we heard this also in Laura's remarks, provisions for impact evaluation should be integrated into program design from the start. And close cooperation with academia or research institutions can be a good way to do this if there's limited in-house capacity for doing so. So before I close out, I just want to zoom out a little bit to position what I'm talking about now in WISE and the OECD's broader well-being work. So mental health is a complex issue. You've heard that many times thus far today, and I'm sure you're going to hear it again throughout the day. And it requires the participation of a range of stakeholders to effectively address. But mental health is not the only complex policy issue. So think of climate change, digital transformation, artificial intelligence. All of these things are going to require systems that enable collaborative problem solving. So taking a holistic approach, factoring in multidimensional aspects of our well-being, and making sure that that's considered in the process of prioritizing, designing, implementing, and evaluating policy goals. That's what at WISE we call a well-being approach to policy. And one way to do well-being approaches to policy is to take a well-being lens to a policy issue, which is what we've done with population mental health in our report. But well-being policy exists in other places, in other forms, and it can go by other names. So the well-being economy, the beyond GDP movement, and so on. They're very much overlapping, and fundamentally, they all stem from this idea that we have to build systems that prioritize the outcomes that matter most for people, the planet, and future generations. So building on some of this work, late last year, WISE launched a well-being knowledge exchange platform. The idea is to bring together international examples of how well-being evidence can be used in policy practice. So it's a platform for peer learning for countries that are experimenting with this and for them to provide technical support to one another. And then the last thing I'll mention in terms of shameless publication of some of our work is that this November we're co-hosting the 7th World Forum on Wellbeing in Rome alongside the Italian government. And this is going to bring together leaders in government, research, business, philanthropy, and civil society. This fundamental question of how do we center well-being at the heart of policy. So I think it's broader than just mental health, but of course it's very much related in thinking about these systems level changes. So with that, I'll leave it here and thank you very much. And if you're interested in learning more about any of our work, please find me at a coffee break or you can find it online here.
Thanks. Thank you, Jessica. Fantastic overview. We'll move to our final speaker of the day, Dr. Claudia Marinetti, Director of the Mental Health Europe. Dr. Marinetti brings extensive experience in advocating for mental health rights and access to care. She'll be addressing the critical issue of building resilience and recovery-oriented support in the face of ongoing crisis. The floor is yours.
Thank you very much, and I'm very pleased to be back here and seeing some known faces of EuroHealthNet, because I used to work at EuroHealthNet 6 years ago as well. I think, Nicolas, we went at the same time, more or less. So there you go. Yes. So Mental Health Europe, just very briefly, we are the main independent European organization that works on the promotion of good mental health, on the prevention of mental distress, and on the protection of the rights of persons with psychosocial disabilities. And we very much also work to tackle stigma and discrimination. And our members are people with lived experience of mental health problems, but also their supporters, service providers, human rights experts, care professionals, everybody that wants to take a psychosocial approach to mental health. We heard about the importance of the social determinants of mental health, and I remember the radical change in the field of mental health in 2020. We were joking with some speakers that we need notes. There's just too much now. So it was a silver lining, if you want to say this, that COVID-19 was the first big crisis that hit the population almost entirely in Europe. Mental health rose to the attention, and it showed people how situations can cause mental health distress. Because until then, there was still very much this link of mental health problems as linked to issues in the brain, or really linked to the biomedical model, despite the lack of clear biomarkers. Mental health has then risen on the European agenda, which also meant a renewed investment in mental health at EU level. And among the things that after COVID, the European Commission was looking for was, okay, how can we help people being resilient? And a variety of projects were actually launched and funded. And I wanted to talk very briefly about one before moving on, which is Mentality. Mentality, it's coordinated by Mental Health Europe. EuroHealthNet is one of the partners. And we are 7 partners in total. And this basically focuses on vulnerable groups and group resilience. We have 4 good practices, and I will not go into detail in that, but again, you can talk to me afterwards if you're interested. One is the implementation of a map that helps navigating free services. This map is co-created as it is creating a community of users of services and professionals. And it's designed basically to allow people to have a process of self-determination and to regain their decision-making capacity rather than being imposed a solution. We have then team reflection, which is a good practice that is aimed at building resilience in teams for care workers, healthcare workers, and also other types of care workers. A hopeful, healthy, and happy living and learning toolkit and guidelines. This is something that is addressing resilience in children, and it goes from preschool up to secondary school. And it's focused on group building exercises and 16 key life skills, such as helping, understanding, listening to oneself, listening to others, coping with change, relaxing, being assertive, etc. And the last is various measures to support mental health of migrants and refugees in times of COVID, but also with the focus of other potential crises. And one of the focuses of this is making sure that when you help people, you have one mental health professional together with a peer educator from, for instance, a certain refugee community. And all of these good practices are existing and are being implemented in different countries. So we are basically trying to learn what is needed to transfer properly these good practices. These practices focus on increasing resilience for people, but they focus on people, but in a community. So it's the group of children in the class. It is the migrants together in their community with the links to their peers. It is the care workers in their teams. It's very important because resilience is a dynamic process, and it changes depending also on the resources that are available to people. So coping strategies can only go hand in hand with systemic changes when it comes to resilience. We need also to be very wary of narratives that only look at asking individuals or communities to be resilient, because rather than just asking them to be resilient so that they can bounce back from adversity, we should actually very much act on the adversity in the first place, trying to prevent it. And this also links to the need not to pathologize any emotional reaction to abnormal situations. And this is very important. We know that after COVID, there was everything else. We already heard we are in a moment of polycrisis that have further risen mental health in importance in the European agenda. There was a conference on the future of Europe that showed how much people care for mental health. This was really reason. It was a citizen saying, this is very important to us. And since then, the Commission had released their communication on a comprehensive approach on mental health, which included different types of funding. There was, again, for the mobilization of funds, various initiatives were launched. Among them, another example of one of these projects is building capacity of people that are working in the sector of mental health, and they can be healthcare workers, but also teachers or social workers or people working in prisons. And here we're looking into building capacity of these people in various settings, and this project in which Trimbos and EuroHealthNet are also involved, we look into creating a training program and an exchange program. Again, if you're interested in this, find me or Laura later on, and we can talk a little bit more about it. At the same time, so there was, of course, this communication from the European Union, but also we could see that mental health has become relevant in many other types of policies. The Digital Services Act, the AI Act, we heard about this potential directive on the psychosocial risk factors at work. At a certain point, Mental Health Europe was even asked to contribute when they were talking about a toy safety regulation. So it's really, we're seeing mental health everywhere. But now the question is, am I pointing in the right? Yeah. What is next? So there is this nice comprehensive approach, but what is still needed, and this comes from us as civil society, but also we heard from the European Parliament, member states, is having an implementation mechanism that needs to be created, and that includes also, of course, impact assessment. If we just stop ourselves to have a list of good practices or various alternatives, we risk inequalities between member states and people living, being left behind, as people could basically just pick what is, in some cases, easier to do if we don't have a coherent action plan. Many ask for this action plan so that this action plan should also make sure that the right investment is made and it is made long term. While we know that mental health is important, we have the latest Eurobarometer data that says that 90% of people think that mental health should be is as important as physical health. Changes in politics means that we don't know if the focus on mental health will remain the same, and if it remains high, it might not be dealt with the right way. The current crises have removed hope, have isolated, have made people insecure. These not only lead to mental health problems, but really very much to a lack of trust in institutions. The question is, will people become more individualistic or more united in solidarity? We heard about mental health environments. I think what is important is really that we need to build the resilience of community in its larger sense, and communities even. Let's talk about intersectionality. Each one of us belongs to more than one community, and this should be done in co-creation. Co-creation is one of the ways that can bring back trust. This is not a tick-of-the-box exercise. I've consulted with people. It means bringing people with lived experience, supporters, policymakers, service providers, everybody capable of sitting as equals at the table and valuing expertise, even if it is different. And I will leave you with a call for action: unify your communities, learn to co-create, and go out and vote. Thanks.
Thank you very much. I don't think we promised too much, huh? 3 great Great speakers, thanks very much. Now we're going to have a mini exercise. It's not a lot of standing up and sitting down and standing up again. But it's just before we're asking the three speakers to, I'm not sure whether these are going to be very comfortable, but they are going to sit on it. And there's going to be a question and debate session. But before that, it's just as a bit of a thinker for ourselves. We heard an awful lot about working together, about reaching out to other sectors, working with other sectors, about co-creation. But we're also aware that some of you here might be working for more of a general mental health or a dedicated specialized mental health institute or service or research. And some of you might be working more from general public health or health promotion. And so we were wondering, let's start at the beginning bit, the most obvious bit for collaboration. Do we feel that the general public health community and the mental health community are still a bit different worlds, or are we already quite good in working together? So that was our little bit of Caroline thought we should have a bit of a provocative question to wake you up, in case you needed waking up. So please, if you agree with the statement that the general public health community, I always feel part of a community, and the mental health community are still two different worlds. If you feel that that's the case, can you please stand up? Yeah. You can also be undecided, which is the best exercise actually for your leg muscles. Yeah. Okay, that is actually, well, I should be neutral, of course, but I do think that's quite impressive. So thanks very much. You can sit down again. But, sorry?
Although,
I know.
we're going to ask some of the people
Oh, of course.
on the floor.
See, this is why it's good we have two co-moderators. So, Matej.
Luckily, I was watching if anybody would jump up.
Yeah,
so
no.
So
we're going to have to ask you why you opted for this.
Yeah.
So please, those people that stood up just now, can you stand up again? So see, this is good for health. So stand up again, please.
Okay, and who's willing to share why they standed up so fervently with us?
Is this on?
Can you please also tell us who you are?
Can you hear me okay?
I can.
Jet Sanders, National Institute for the Environment, working there as a behavioral scientist. I certainly think there's more engagement with mental health as an outcome measure. So I think that's one way in which we're certainly integrating it in my part of the institute. But I think so much more can still be done. We're still working in different fields. So the funding streams, for example, are coming separately, and we need to find each other to work more together. So I was sort of on the 5 to 7 point scale.
Okay, so you're already on the outcome level.
Yeah.
Okay, so we were still with the community element. So should we ask one more person and then also ask somebody that was sitting down?
Maybe someone sitting.
Somebody that really disagrees and think we're really already quite close.
My name is John Dierks. I'm a professor at the Avans University of Applied Sciences. And I rather disagree, because I think there's a lot that's been happening already in the general public health on the mental health community. As in the neighborhoods, we are working closely together with social departments, with mental health communities. So I don't see the difference that much. And also policies are more focusing on tagging both. So I'm not. That's why I don't agree with the statement.
Well, thank you very much. It wouldn't be the first time that local action and policies will be at the forefront for collaboration. Huh? So thanks very much. Okay, Matej. I think also time-wise, I think we need to move on. But at least you've been up and down a bit and started to do some thinking. So we are going to invite the speakers now back up on stage, and Matej is going to take over from you again.
Indeed. So please, the speakers, if you would join me on the stage. Nicoline, are you gonna? Yeah, I'm going to share the microphone.
Let me climb first. Thanks.
Yeah.
Thank you.
Here you go. Okay. Well, we're at the stage that I have said we're gonna end up in. So questions prepared, I believe. Does anybody want to go first, or do we need any clarifying questions, maybe regarding what was presented already?
Could you stand up, please, and introduce yourself? Yes.
Sorry.
And you have a microphone? Because we have lots of online people as well, huh?
I'm very curious to the missing part of your presentation. Is it a lot, or is it? Can you put it in a few in a few statements?
Actually, I think the slide of Jessica presented it on a very visual way, so that can be referred back to, but it was basically to have a combination of income supports or supports with housing to bridge difficult periods, having early life home visits for new families. That's something that we know from the evidence is both cost effective and effective, both in terms of current mental health, but also mental health outcomes later in life. Having well-being at school approaches, having healthy workplaces, access to social activities that reduce social isolation and loneliness. So having that mix of different types of activities and supports that not only keep us going well and keep us socially connected, but also prevent us from getting worse when we do need help, and that we have timely access to it. And the last part was a combination, so like a healthcare center that also has social care and mental health care in place under the same roof. That exists already in many countries already, but the financial streams are quite difficult to align since they usually come from two different financial support sources.
I think there are some examples in the Netherlands, in Nieuwegein, I think.
Yep.
Thank you. I was Duke van Dalen from the RIVM. I'm sorry.
This is a reminder for people that want to ask questions, please do, to introduce yourself briefly. Thank you.
Thank you.
More questions?
Oh. Second row is active, yes.
Hi, Philippa Marbeck, Sweden. So if mental health and public health are two sides of a coin, why should we have mental health in all policies when we have health in all policies?
And who would you like to answer that question?
I'm happy to at least start. So I think it's a good question. And I think, is this still? Yeah, it is still on. Okay. At least in some of the work that we've done and some of the people we've talked to, there's a bit of a critique of, mental health in all policies, or even health in all policies, of seeing it being very much health center focused, very centered on the health sector. And so then health priorities are being added to the portfolio of all these other agencies without a budget, and it's sort of uneven. And it creates an environment, sometimes in some places, I'm sure not always, that's a bit antagonistic or confrontational as opposed to more collaborative. And so that's kind of the point we're trying to make here with well-being approaches to policy. Again, it doesn't always have to mean that the policy focus at the end is the promotion of mental health or the promotion of good physical health. Is that distinction even useful? That's another conversation. But the idea that you have systems that enable this type of collaborative work, because what health in all policies or mental health in all policies is trying to get at is this idea that these things are all interlinked, and it's silly to try and do it separately and pretend that those outcomes don't influence each other. Something in the report we're trying to do is also just to say there are some easy wins here, because look, and Laura, you talked about this a lot. There are policies that are happening elsewhere currently that have no explicit consideration of mental health in the way they're talking about it, that have huge mental health benefits, actually. Like, look, you're already working in this sphere. Here's an easy win. And so that's a little bit what we're trying to do too, is to make the case to non-health agencies. You do have a role to play, and in fact, you already are playing that role. So let's think about how to kind of work together.
Can I just briefly come in and say, well, see, Claudia, her organization basically your key role is to come in on the specific elements of mental health, right? So if you look at the question, you know, why would we not just put everything on one big pile and say you need to focus on health and all policies rather than mental health and all policies? What would your reply be?
That mental health is also health, but it's not only health. And there are various issues here. It's how traditionally mental health has been interpreted. I was talking before about the pathologizing of mental health, which means that any kind of emotional reaction now might be marked as mental health problem. There is the issue that mental health, so just when you talk about mental health, you immediately think about the mental health problem, yet you don't do the same with health. So there is really a lot that needs to be changed. There is the issue that when you have most physical health problems, you can still be in the driving seat, or it's more acceptable than if you have a mental health problem. There is a lot of stigma there because people think that you cannot think for yourself. There are all of these elements to take into account, and for which I think it is still important to make this distinction. There is the issue that I think I mentioned it before. There are not clear biomarkers linked to mental health problems. So even the whole concept of diagnosis, it's very different. We need to approach mental health differently, and it is sometimes even very much linked to learning to accept diversity, for instance. It's really a different time that goes hand in hand with physical health. It's as important as physical health. It is not equal to physical health. And just one quick thing about this, when I said this diagnosis, that it's a bit, in one of the last manuals for diagnosis, there was even a long grieving disorder now. Where are we gonna stop?
What disorder?
Long grieving, like you cannot, if you're grieving too long because you've lost someone, there's something wrong with you. You have a mental health problem.
Yeah. Okay, I'm just going to take it to Laura now, still on your question, which is super helpful. Because you're saying something about, well, we need to look more at mental health impact of policies, right? So that again suggests that there is some need for specific focus. Could you share some of your views on that? Wow.
Why it's important?
Yes, and also what then would be what we needed to look at mental health impacts, which of course I know you're going to do some work on soon.
Yeah, I think there's so we do have a lot of research already on the impact of mental health interventions on therapies, for instance. There's a lot of that, and also on interventions for specific groups with a high risk of mental health problems. But what we know less about is what the impacts of a policy intervention that intervene on something as broad as a social determinant, what effect that has on mental health and how. So we need to do more research on actually understanding how these policies, and what are the mechanisms that these policies are acting on people's lives. And that's already starting a little bit with, especially in the income policy field, with tax credits as an example, or other forms like paid maternity leave, and looking at the impacts of these types of policies on psychological distress and also positive mental health of populations. But that's still quite in its infancy, and we need that to be able to inform, do we need to change this policy? Does it make a difference if we increase, for instance, the amount of money that's given in this income support policy? Does that correspond to an increase in mental health? Should we stop doing or offering certain types of supports in our policies? We don't have answers to a lot of these questions, but this potentially can impact the mental health outcomes of many people at the same time. So it's really important that we find more answers to those questions. But historically, the research has been more in the income and housing space. Thanks.
Thank you. Yeah. Now that we're talking about different aspects of mental health, at the same time, we're talking about upstream policies and factors, and on the other side, pathologizing different experiences and so on. And at the same time, we've all said mental health has gained increased attention over time, and we expect it to increase even more. Now, I would love to pick your brain on, like, what do you think? Is there something that we as a public health community are not doing well enough, so that we have so many diverging and conflicting ideas on what is and what is not mental health? Or is it something that is currently outside of our scope and yet to be tackled?
Is that to me or to all of us?
To all of you.
Co-creation? That is something that some are doing. Some are doing already quite well. There are examples. There are good examples in the Netherlands, in Ireland, but in a lot of other places it's not done. And even at the level of institutions, it's not always done. So it's a tick of the box exercise instead of being done properly. And if you want to know what the real needs are and what the situation is, you need to ask to the people that are affected by the problems and the people that are going to be affected by services and by policies. And it can be a bit messy and it can take a bit of time, but basically we cannot afford anymore to have policies or practices that are not efficient and that don't work. And that, I think, is the only way forward, and it will also bring trust back.
Claudia, just one mini question.
Yeah.
If you say co-creation,
yeah,
which is one of these fantastic buzzwords, but then we think we know it, that's not in a negative way, but we say it and then we think everybody means the same with this. So that's what I'm asking. So would co-creation also mean, for instance, bringing in people that are not yet suffering from mental ill health, but are from the vulnerable communities? So people living in poverty, people that are the young kids that feel very stressed, single moms that live on very low incomes. So would that also be about co-creation, or would it just
can be? It depends what you're trying to develop, and it's very interesting. So you were saying the single mother to always take into account intersectionality. Trying not to go to with the usual suspects.
Well, I'm a single mom, so it'd be nice to be co-creative. No, I'm only joking, but it's really about, who are you wanting to put around the table?
It depends on what you're trying to do. So if you're trying to do a general policy to support and prevent mental health problems in young people, then the suggestion would be to get the people from various backgrounds and various communities. Mm-hmm. It can be people from low socioeconomic backgrounds, people from LGBTI communities that try to cover the intersectionality, and people that are on a recovery path, so that have been through the problems and that they know what helped and what didn't help. And if you're interested, because I know that it can be as a concept a bit vague, but we have developed Mental Health Europe guidelines and a toolkit on co-creation, which it's a mental health
available on your website, I presume?
Yes,
excellent.
It is.
That's great. Thank you. Yeah.
I was going to say something sort of related to it, so I'll be quick. But just to say on this idea of co-creation or collaboration, et cetera, some of the lessons from our case studies is that this often happens in the beginning in the design phase, and then it's not kept throughout. So it's early stages and then it drops off. So thinking about how to actually sustain that in a real way and in a planned way. The other thing in terms of specifics of who, a lot of the case studies that we were looking at had a special focus on children and young people and their mental health, and that working with them was difficult in practice, especially for school-based interventions, because it takes so long, the consultative process and then implementing, that by the time the program was implemented, those kids had already graduated and they were not in school anymore. So it's a very practical issue where it was frustrating for them. They didn't really feel like, what are we gaining from this? So I don't have a solution there, but just to say that I think when you actually look at the practicalities of what a lot of this entails, there are still some knots to sort through.
That's true. I think that then when they will be a bit older, they will be grateful that they could participate.
Their civic
to that.
duty.
So they need to be indeed a bit patient.
Laura?
Very quickly, I agree with everything that's been said. 2 additional points is that, like I mentioned in my talk, we're very good at inventing new things. We're not very good at sustainably implementing things, and that goes for public health as well as other areas of our lives. So I think really asking the question, do we need a new intervention? What need does that fulfill in our community? How does that relate to what they need, and how might that work? I think asking the more questions that relate to why, and then the how, that really needs to guide sort of the future if we need to really develop more interventions in different environments and new policies. And the second is that, at least this is my experience, that we often hear from many mental specialists, which are incredibly needed in our societies, that they're really struggling with longer waiting lists, with not being able to meet the needs of the population. So we need each other. They can work more in prevention, we can work more with specialists, but really talking to each other and finding a common language and a common goal, I think we can do that better between public health and more specialized mental health in this case.
Sorry, just to add very quickly another 2 things. Yes, let's reflect on, do we need, but who are we going to ask? Do we need? We cannot just talk among ourselves. No. Yeah. And then about the point that you had made, you just involve the people at the beginning, but not later on. There are actually good examples. One of them is in Ireland with their sharing the vision policy, of being able to keep on the people in a group that is monitoring actually the implementation, which is very important.
Okay, thanks very much. Matej, do you want? We're not supposed to give somebody yet again another. If there's still one person with a wonderful question, then we could take a quick one.
Yeah.
I'm with the National Institute of Public Health Slovenia. I don't know if it's quick, but when I'm listening to that, I'm wondering if we're now working in traditional mental health and that what is happening in digital mental health. That's something what I see as a really such a substantial change. And listening to all of that, I have sometimes feeling that, okay, we are speaking about the traditional environment we are all used to live in and work in, but there is another completely new world appearing. It's the digital one. So that applies to both, or is there any difference? How to approach that?
So this would still be about mental health, but just in the digital world and in the real world, which is to some people also digital. Who would like you to respond? Who would like to respond to that?
Not yet, but just a clarifying question. Do you mean, I don't know if this still works. Is it regarding treatment, or is it regarding just the influence of our social environments? Okay, everything.
Well, we have a report on digitalization and mental health that looks at and our social lives in terms of mental health care and also in the workplace. There are potential good things and there are definitely risks there. And I'm not sure where we want to go, but I think that it's something that is evolving very fast. Specifically in care, for instance, we need to be wary of the fact that it can create further isolation, and we know that isolation is a risk factor on mental health. And then with AI, it's a whole other thing, because now they're also thinking about providing support via AI, but where is AI getting their data to provide support? Which model? Are they going to go into a biomedical model? Is there how can they really interact with the person to understand their experiences, their relationships, etc. So, but yeah, I mean, there is a lot, and I'm happy to talk about the other aspects of digitalization and mental health, because that's something on which we're working quite a lot in Mental Health Europe.
It might also be good to clarify that when we speak about mental health, we mean mental health and not mental health services or mental ill health or the impact of digital environments on mental health. And we tend to, put everything under one umbrella, but then we mean different things. So that might already help a little bit. Yeah. I'm afraid I need to. Time's up. This is where Caroline, you can't see her, but she's at the front row. And she wasn't supposed to wave red and yellow cards around, but she does now. So time's up, I'm afraid. I was supposed to wrap up, but it's a bit difficult with three of such wonderful speakers. But I do think going into tea, coffee, and whatever nibbles we have, there is a lot for us to do. And the trap is like invent yet again another wonderful intervention. We really know what to do, and we can also learn from the health and all policy work and the integrated policy work, but we should be aware that the impact on our mental health might be different, and be aware of that and develop new knowledge about that. I think partnership will be the key, and bringing in other sectors. We know how to do that in a way, but maybe not so much around the area of mental well-being. So there's lots to be done. And with that being said, I want to thank you for your attention, and my co-chair for co-chairing, and of course our three wonderful.
Welcome back also for our online participants. Please bear with us. We're coming back from the coffee break, and we have a full room. And people like to talk, which is good. Lots of talking and networking, which is important at these events, which is a bit harder to do online, unfortunately. All right. Please take your seats. So we can start with our second session on behavior and culture insights for better health equity decision making. And I have the pleasure really to introduce to you our next set of co-moderators. It's Marijn de Bruin. He's Chief Scientist of the Behavior Unit of RIVM, and Yvette Shadjani-Anzane. She is the head of unit of BZJA, and that is the Federal Center for Health Education in Germany. And Yvette is also an executive board member of EuroHealthNet. So the floor is yours.
Thank you. So, am I live? I'm live. Yes, I can hear it. Excellent. Okay, well, welcome to the session. I'll give a very brief introduction and introduce the first speaker. And then the speakers number 2 and 3 will be presented by my co-host. As we all know, mental, physical, social, and environmental health are strongly associated with our lifestyles, our living environment, our food environment. However, it's often very tricky and difficult to get these types of behavioral and cultural interventions into policy and practice. And that might be because sometimes if you look at those systematic reviews and meta-analysis, you see that the effects of those interventions are often small to moderate. That might play an important role in their low uptake in policies. But although this varies between different countries, in COVID times, we've seen massive behavior change. So reflecting on some of the key components that made COVID maybe different from food behaviors and overweight, which has been not as successful in addressing. What we could see during the COVID times is that we had very concrete, measurable health goals that governments committed to. We were seeing a sense of urgency to address an urgent public health issue together. We were seeing health communication and health policies directed at the system at the same time. So the health communication and the policy interventions directed at the systems were aligned together. And organizations and people were going all in for the common good. So there was much less bureaucracy and there was much less focus on individual careers and interest for the own organization. So I think this might be a secret recipe for making health behavior change interventions matter. So the whole pandemic that I'm referring to sparked substantial interest in behavioral and social sciences. There have been various countries where investments were made in behavioral science units. And this is also the bridge to the first speaker, who actually started the WHO EU Behavioral and Cultural Insight Unit in the beginning of 2020. So not because of the pandemic, but very well timed with the pandemic. And her name is Katrine Habersaat. Yes? Perfect. So she's the lead of the Behavioral and Cultural Insight Unit at the WHO Europe. We go one pandemic back because I'm in the technical advisory group of the WHO, and that's how we've met. She's got a highly dedicated and competent team that produces very frequent reports. They've contributed substantially, of course, to the EU resolution on behavioral and cultural insights. And if you follow Katrine on LinkedIn, you're wondering if she's maybe part of a triplet. She's like all over the place at the same time on lots of different topics. So I'm sure you're going to tell us now how we can do that ourselves. So Katrine, welcome to the stage, please.
Thank you, Marijn, for that introduction. Just going to see how I can somehow see that. Can you hear me? All right. I'm so glad you decided to put behavioral cultural insights on the agenda today because I'm not sure how this one, there we go. So, because behaviors are absolutely essential to health, to well-being, and to our mental health as well, it's how we behave in our everyday lives. It's our lifestyle behaviors, what we eat and drink, and whether we're physically and socially active. But it's also how we interact with our health systems, whether we follow a treatment plan, whether a physician prescribes antibiotics or not, and how she interacts with her patients while doing that. So it's really, really essential, and it's in acknowledgement of this essential role of behaviors in health that WHO Regional Office for Europe, and Marjolijn called it EU, but it is an extended European region with 53 member states in Europe and Central Asia and the Caucasus and a little bit in the Middle East and Balkans as well. So it's a very large region we cover. And in that region, with WHO, Behavioral and Cultural Insights, or BCI as we call it, is a flagship priority. We define this area of work as mainly three different things. On the one hand, to understand all of the many factors that affect a given behavior in a given target group, the individual factors as well as the environmental factors, and we learn that through global evidence as well as local studies, and then using all of that knowledge to co-create policies, services, communications that seek to enable and support or even restrict sometimes behaviors, and then importantly evaluate these interventions as well to see if they really work. And we find that this is a people-centered and evidence-based approach to behaviors, and one that acknowledges the complex and multifactorial nature of behaviors. And behaviors are also not just at the heart of health, but really also at the heart of health equity, because our living conditions, income, education, level of inclusion in society and stigma, all of that drive our behaviors and then has an impact on our health outcomes as well. So the link to equity is really critical as well. And we know that these broad scale interventions like information campaigns that seek to sort of focus on an entire population that really often have limited effect, and particularly with those who are experiencing disadvantage. So if we want to spend our money wisely, if we want to try and reach those that are experiencing disadvantage, we need to tailor our interventions to the needs and circumstances of those who are affected. And that's what we're trying to do with our how-to guide for BCI. We call it a guide to tailoring health programs. So it's all in the name. It's about tailoring. And this is one of the documents that we use a lot. You can find it on our website. It's one out of several guidance documents and policy documents that we have developed to support health authorities apply behavioral and cultural insights to health. We also work directly with countries. These are just some examples. We work, as you can see, with behaviors across many different health topics and a very broad geographical scale as well. We also work a lot with capacity building, lots of in-country face-to-face trainings, but also we have an online training. So if anybody would like to go and access it, you can find the link here or on our website, and then you can just go through the self-paced modules. But I do think the heart of our work is our direct collaboration with the member states in our region. As I said, there are 53 member states, and they've all nominated a BCI focal point, and we meet with them very, very regularly, and we worked with them to develop a regional resolution on BCI for health, and that was followed by a global resolution as well. And the regional resolution outlines 5 strategic commitments for countries. So countries have said, yes, we will invest more in this field. Yes, we will do more work in this field. And they've also made a commitment for the first time to report back to us on their activities in this field, which is unique because we've never known before what the extent of this work was before. So we've received the first reports from countries, and to go beyond that and also understand that data better, we worked together with the ECDC to conduct an interview study with the BCI focal points I mentioned before to understand how they see the barriers and the drivers to advancing the use of more people-centered, more evidence-based approaches to health behaviors in their countries. And these 2 reports together really provided very useful insight that is driving the work that we do and our collaboration with countries. We know from this reporting, and this was reported in 23, so it covers the years 21 to 22, that half of the countries said they've done more than just a few behavioral or cultural insight studies. And of course, this was also the period of COVID, so many countries actually did a lot of studies during that period of time. 1 in 4 said that in those 2 years, they conducted at least one impact evaluation of an intervention that aimed to support behaviors. And then 1 in 3 said, we have at least some level of funding or people dedicated to this area of work. And I think that's fairly encouraging as a starting point. But the report also very clearly says that this work isn't very well integrated or structured, very consistent across health areas. And we can also see that some of the important gaps relate to skills, to knowledge translation, having the structures and the communication lines in place to go from these insights to policy making. And also we can see that capacity building and insufficient human and financial resources are the challenges that we see in the countries. However, it is very clear that there is a momentum and that there is a lot of appetite for advancing the use of these methods in health in our region. Before we published these 2 reports, we discussed them at a meeting with all of these BCI focal points in September last year, and a lot of experts and partners were there as well, including the EuroHealthNet, and we discussed them, and then we went ahead with a meeting statement that we've published with a lot of sort of very concrete steps for where we need to go from here. So if you would like to hear more about that, you can read the meeting statement. But I think most importantly, these 2 reports and the meeting together really provided very good guidance for us in terms of, from countries to us, in terms of how they would like to be supported in advancing the use of people-centered, evidence-based approaches to health behaviors. And in short, they say that the resolution, these commitments that countries are making, the reporting, are really strong drivers of change. And the fact that WHO is putting it on the agenda, the fact that other partners are putting it on the agenda, means a lot for advancing the use of these methodologies. They also say they really need international bodies like EuroHealthNet and WHO and other partners to ensure that there are platforms for country exchange. So we're here today for collaboration, but also for capacity building. And then I think importantly, they say that the more we put this on the agenda, the better. And then this is the key message I will end on. The most important thing we can do is to support the BCI spearheads and other experts in the countries in setting their own agenda in their own country setting for how it works in their setting to advance the use of more people-centered, more evidence-based approaches to health behaviors. Thank you.
Yeah, thank you very much, Katrine, for your wonderful input on BCI approach of WHO. The next topic we would like to address in this session is on pre-environmental behavior. And there is no better person who could give us an input in that than Dr. Sanae Okamoto. Dr. Okamoto is a psychologist and behavioral scientist at the United Nations University. As co-leader of the Climate Resilience Initiative of the United Nations University, she has been spearheading research at the intersection of climate change and mental health as one of the pioneers there, and is active in international advocacy work in that regard. The floor is yours.
Thank you very much. Thank you very much for having me today. It's a great honor to contribute to this amazing occasion. I'm Sanae Okamoto from United Nations University. So United Nations University is a research think tank and a training institute for United Nations. We have 13 campuses across 12 different countries in the world. And one of them is located in Maastricht in the Netherlands. So today I would like to talk about leveraging pro-environmental behavior for human and planetary well-being. So climate change affects our health in many different ways. Extreme weather events increase mortality, injuries, illness, and mental health conditions. Yeah. In globally, the 3.6 billion people are living already in the highly climate vulnerable regions, and also the polluted air kills more than 5 million people each year. Furthermore, climate change also damages many key infrastructures and social systems, and also disproportionately affects the vulnerable populations. If we look at how climate change impacts our mental health, at the left side, you can see how the community is directly being affected by climate impacts. So you see like people lose houses, and also the people get exhausted by extreme heat, and also the damages in agriculture and economic income, and the forced migration due to the extreme weather events. And then if you look at the right side, you can see how communities indirectly affected by climate impacts. So people also suffer from the witnessing changes in the familiar environment, and also watching shocking news. So it is very clear that engaging in pro-environmental behavior is very important, and also this is really like it can result in very large gains for human and planetary well-being. So taking care of mental health is not trivial. It's also not only individual health. It impacts you and your family, your partner, your children, your friends, and your community. So it is about community health. 1 billion people worldwide are currently living with mental health conditions, and many of them don't have proper support. However, in many countries, on average, only about 2% of government health budget going to mental health support. The situation is even more severe in places where health systems are inadequate. Moreover, for the population has a stigma and cultural norms and taboos towards mental illness, so people also don't often talk about their struggles and problems, and also don't seek for proper support. So aforementioned by Commissioner Schmit, European Commission's comprehensive approach to mental health noted that 46% of EU citizens had psychosocial problems in the last 12 months, and 25% of the citizens had issues accessing mental health services. So even without considering climate change, there is a considerable lack of capacity with coping the already existing need. So, and the climate change is adding a huge extra burden on our health systems. Climate change sounds big and overwhelming and may cause us anxiety, but it is in the end caused by human activity, human behavior, hence human psychology. So with action to tackle climate change requiring a reshaping of our lifestyle to minimize the emission of greenhouse gases. So it is important to understand how humans react to climate crisis, and also we need to make sure we need to involve as many as people possible in the environmental action. So some people might react to climate risks with a fighting response, like by engaging in climate activism, and some people might react with a flight response, like the run away and avoid the problems altogether. And some other people might get the freeze response and get paralyzed and get scared and cannot do anything. There are so many ways people react to climate crisis. So therefore, public engagement effort must start with the recognition that people have different psychological, cultural, and political reasons for acting or not acting. So for this, behavioral cultural insight can be a great tool. So therefore, BCI can help us understand human psychology to engage many people as possible in multiple approaches. So because research shows that engaging in pro-environmental behavior that provides a greater sense of agency and also solidarity, and also gives a feeling of control over climate change. And this also significantly reduced the symptoms, the climate anxiety related to this depressive symptoms. And there are clear the co-benefits of engaging in pro-environmental behavior for both human and planetary well-being. So there are some key points, the potential touch points for us to engage in pro-environmental activities. For instance, schools and climate education. how many of us had a chance to learn about the climate change in our or your school settings? Or how many, that's nice, great. How many of us or teachers, are comfortable to talk about climate change with our children? So they are really difficult, tasks. And the program for international student assessment, it's called PISA, conducted by OECD, will include the measurement of knowledge about climate change for 15-year-old children, starting from 2025 program. So this is starting soon, and many countries have been establishing guidelines for preparing educators, teachers to be ready for this. And it is also good to engage in community-led activities, but also there are also citizens' assemblies on climate change. They can function as a platform where communities, scientists, also the mental health professionals, and also the government officials can collaborate and build trust in climate action. Participants also can share their feelings and concerns about the future of the planet, and also gain knowledge about climate change and promote collective action. It is also important to utilize advanced technologies. AI and natural language processing tools can identify and detect the trends of mental health condition in the population. And through language patterns and images in social media posts, now you can also do these kind of things. And for doing that, public-private partnerships is very useful. So you can involve technology with the social media companies, NGOs, and governments, and to develop predictive analytics tools to detect issues early and provide swift and appropriate interventions and shape national mental health policies. And also, since the COVID-19 pandemic, digital mental health care through teletherapeutic apps have developed rapidly. And these are very effective for people living in remote areas to access the care support, and also reduce the cost of receiving care, and also reduce the stigma and the fears towards mental illness. However, utilizing such new technologies, you need to be very carefully regulated to minimize risks to security and privacy issues. And also some weeks ago, WHO regional office, European regional office, has published digital health landscape in WHO European region. And there is a rapid advancement in digital health landscape, and mental health can take a great advantage of such a development. And lastly, it is necessary to develop tailored behavioral interventions. To summarize, we can utilize BCI, behavioral cultural insight, to help developing a climate resilient society to build psychological resilience in ourselves. At at UNU, we have published a series of policy briefs on this matter. So please feel free to download the policy briefs, and also we look forward to hearing your feedback. Thank you very much.
So thank you very much, Sanae, for your wonderful input. The last topic we would like to address on BCI is the digital behavior. We have invited an academic for that. This is Dr. John Roozenbeek. He's a lecturer in psychology and security at King's College in London. His research topics are currently digital behavior, polarization, and misinformation. And in this regard, he worked also on vaccination hesitancy during the COVID-19 pandemic. The floor is yours.
Thank you very much. Just sort of checking if this works. Yes, great. Okay, so I only have a couple of minutes, so I won't be talking about sort of the whole breadth of my research or even the whole breadth of relevant health behaviors. But one that I will mention is that relates to how digital environments shape our behaviors, our attitudes, and our beliefs. And in one study that we did in 2022, this is led by a colleague of mine named Steve Rache, we looked at, we measured vaccine attitudes, basically how positively do people feel towards the COVID-19 vaccine at the time. And we use that information to sort of map their behavior on social media environments, in this case Twitter, as it was still called at the time. It's now called X. And one very robust finding from psychology behavioral science is that people tend to cluster into like-minded groups. And we wanted to see if that was also the case with respect to vaccine attitudes, because that is very important if we want to, for example, reduce vaccine hesitancy or increase vaccine uptake. We need to know who to talk to, who has, skepticism towards vaccines and who does not. And what we found was extremely interesting. So we did the same analysis in the United States, in the United Kingdom. And here you see the results for the United States. And these are two clusters of high and low vaccine trust. And as you can see, the cluster on the right is low vaccine trust. The cluster on the left is high vaccine trust. And what you can see is that this maps almost perfectly onto political divisions in the United States. So you see here on the right, Donald Trump Jr., Joe Rogan, Sean Hannity, Jim Jordan, Ben Shapiro. These are all right-wing sort of political figures in the United States, be they politicians, be they political commentators, and so on. And on the left, you see Bernie Sanders, Michelle Obama, Hillary Clinton, etc. In other words, political figures on the left. And this is not a clustering of political divisions in the United States. This is a clustering of high and low trust in the vaccine, which means that in the United States, we have a very strong overlap between the political realm and the health realm, right? And that's a bit of a problem. Luckily, this appears to be a problem in the United States, because we did exactly the same thing in the United Kingdom, and we found no such thing. We found if there was any clustering at all, which didn't really exist, because basically everyone had far more trust in the vaccine than most Americans did. The clustering was much smaller, and it took place along maybe sort of class divisions, if you will, but not really political divisions whatsoever, right? And so that means that if we're thinking about health behaviors and how these behaviors play out online, we also need to think about how politics plays out online, how polarization works online, and so on, right? So if we were to repeat this same analysis in the Netherlands, we might find a completely different result, and we might find that there is a very small cluster, let's say, of people with a certain political preference or otherwise, who do cluster into sort of low vaccine trust communities, and then a much larger community that doesn't, right? Either way, we haven't done that study yet, so we don't know. My own specialty, I suppose, as far as research goes, is related to the role of misinformation in explaining relevant behaviors, attitudes, and beliefs. And the first question you might ask, which is also why I put up that slide, what is misinformation? Then there's a lot of debate about this going on within the research community. I wouldn't call this misinformation, even though it's completely false, right? As far as I know, Kim Jong-un was not named sexiest man alive in 2012. So questionable whether you would call this fake news. But more broadly, if you sort of look at the consumption of this type of fake news sort of in the media ecosphere, this is what you find, which is you won't be able to see it even in the front. There's all sorts of shades of blue and green and so on, I think, because I'm pretty colorblind. There's also supposed to be red there. That is fake news, but you can't see it. The reason is the consumption of it is really, really low, by which I mean fake news, meaning demonstrably false news headlines, people don't really see, right? So that's interesting to know. So does that mean that we don't have a problem? Certainly not. The problem, at least as far as I'm concerned, relates much more to people making false inferences based on incomplete or misleading information. And once you do that, all of a sudden you find that within the realm of health behaviors, we have a serious issue. This is a study that was led by a colleague of mine, Sahil Lumba, who collected about 16,000 survey participants, which is a lot in the United Kingdom. And he wanted to know, is regional variation in vaccine uptake related to misinformation belief? And so we have a standardized test that measures how good you are at basically detecting misinformation, right? It took a long time to develop, but here we are. And Sahil correlated performance on that test with people's postcode in the United Kingdom. And so what you find is that controlling for everything else, and here on the right you see the things that we control for: population density, gender, age, income, unemployment, life expectancy, whether you voted for Brexit, etc., etc. And even when controlling for all that, we find that the degree to which someone is likely to believe misinformation was independently associated with vaccine uptake, meaning not vaccine intentions or anything like that, actual sort of vaccination rates at the regional level. So that already provides an impetus, I think at least, to start considering this to be a problem that we should probably tackle. Another relevant study here that sort of demonstrates the consequences of the consumption or excessive consumption of misinformation is this one by Skylar Johnson and colleagues from 2017. And Skylar Johnson looked at survival rates of cancer patients who choose for conventional treatment versus unconventional, sort of untested treatments, alternative therapies. And here you can see the difference, right? At the top, the dotted line is people who opt for conventional cancer treatment, and the sort of solid line is for people who opt for alternative cancer treatments. And you can see that especially sort of 84 months after sort of diagnosis, you see that the survival rate for people who choose conventional treatments is about 75%. And for people who choose alternative treatments, it is roughly 50%, which is a huge difference. Are all alternative cancer treatments directly related to misinformation? Difficult question. My argument is that roughly yes, because you do need to make a decision that affects your health based on information for which there is no evidence. Otherwise, it would not be considered alternative therapies. They would just be regular therapies. Okay, sort of jumping through this a little bit. What can we do? Already several speakers mentioned this distinction between individual and system level interventions, right? And so that difference also exists with respect to tackling misinformation. And so at the individual level, we have quite a few tools available: debunking misinformation, labeling misinformation as such, pre-bunking, digital literacy, those kinds of things, but also nudging, which are aimed at sort of, boosting relevant behaviors. The summary of that is it works kind of well-ish in a lab, but not for very long. And it doesn't work as well in the field, meaning in real-world environments. Doesn't mean that it's completely ineffective, but it's the same debate that every behavioral scientist is very familiar with, which is to say small effects. In defense of these kinds of interventions, they're also completely harmless, meaning they make no meaningful changes in people's lives in the sense that they are completely rights-preserving, et cetera, most of the time. Meaning if someone, I don't know, takes a course on how to spot misinformation, their rights are not being violated, right? And then we have system-level interventions, which are much more impactful as far as effect sizes go, but also much more impactful as far as consequences in terms of freedom-preserving interventions go, right? So what can you think about in those cases? Well, for example, you could ask Facebook kindly to change the algorithm that they use to recommend people different kinds of content. That has been tried, interestingly, by a team of researchers from New York University and a bunch of other universities last year. And they found that it doesn't really matter, meaning there's no major difference in terms of many important outcomes between the algorithm that Facebook currently uses and a chronological algorithm where you just see the most recent post first. Very interesting. Does that mean that algorithms don't matter? I highly doubt it. I think there were some limitations about that study that we should probably consider. Either way, what's extremely difficult here is to figure out sort of how do these interventions kind of work in isolation, right? If you change an algorithm, what does that do to a variety of relevant outcome measures? If you address sort of how people are allowed to advertise certain kinds of content, especially political content to people, how does that affect not only the consumption of misinformation, but also polarization and in turn, health behaviors? Those are things we simply do not know. What I wanted to end on is a debate that I think is often kind of underestimated a little bit, and it takes place within this realm of individual level interventions, which is how do you get these interventions to people, and how especially do you get people to participate in these interventions voluntarily? One thing that we tried was we created some online games, which we hoped would attract a type of person that might enjoy playing an online game, and we did it from the perspective of the bad guy, basically, right? So in these games, you play as a person who spreads fake news for fun. Why? We thought it would be entertaining, right? There's some psychological theory about perspective taking and so on that underlies it, but more practically, you have to get someone to voluntarily decide, I'm going to go do this. And one of the ways that we did that was with humor. We tried to make it funny. Unfortunately, I've since received my PhD, and therefore I've also lost my sense of humor. This is a standard, so I can no longer do this. But there are plenty of people who still can. And so that is also what I hold out hope for, that we can find ways to kind of circumvent this skepticism that often, I think, rightfully exists when it comes to especially sort of large entities designing interventions, right? I do this from my ivory tower, right, in the academic world, trying to find ways to organically reach people with relevant information and reduce skepticism in that manner, which is completely unsolved. So I will end here. Thank you so much. And if you have any questions, this is my email address. Thank you.
Yeah, thank you very much for the wonderful inputs we had. We have also a question like the last session. Yes. So the question is whether we need to be better in applying behavioral sciences in order to understand and improve health equity. If you agree with this statement, please stand up. And remain standing. Oh, it's actually hard to find somebody. it's actually. Yeah, but here are more people sitting.
Yeah, well, we're first going to go for the standing.
We
right?
go for the standing one, actually. Yeah.
So let me just be assertive, and then no escape modes. Are you willing?
Yeah, okay, so I stand up because I think that is never enough to improve health equity, so we need behavioral sciences to this, so that's why I'm standing.
Right. The more the better. Yeah, okay.
Should we go for somebody
who's sitting? Is there somebody sitting?
Yeah.
Yeah, okay, let's go
Very
to the
few
second
ones.
row.
Am I hearable?
Yes.
So I think not per se. I think for a lot of questions in terms of health equity, we kind of already know what to do. So for instance, with regard to improve mental health, the example we heard already earlier today, we kind of know what CSU, right? We just have to improve people's financial situation and housing situation. So I don't necessarily think we need more knowledge. I think just we need to implement the knowledge we already have. And I think that is the case for a lot of other issues as well.
Thank you very much. Okay, so the more the better. We already know. Oh, Yuka.
No, we need a microphone. People don't.
Is that not exactly the reason we need to know more how to implement, and then we can use the behavioral change? Oh, okay. Yes, but we need to know much more about how to implement, and then you need more behavioral change insight.
Yeah, and I think many people would consider implementation science to be part of one area of behavioral science, but more at the system level. But I think they are all very good points. Thanks.
There is.
Oh, yep.
As I sat down, I thought I should say something. So my name is Mark Pettigrew. I'm a professor of public health. So I suppose my immediate reaction to this was that the evidence base actually shows that everything that we know about behavioral interventions is that they actually increase inequities. So I was sort of surprised that almost everybody stood up at a public health conference. So I'm still sort of processing this. And I think it sort of reflects what Margaret Whitehead and others called sort of lifestyle drift in public health, that we start off talking about the need to change structures and environments, and then we drift down towards thinking about the sort of interventions that people need at an individual level. So that's why I sat firmly in my seat for this one. Thanks.
So we don't need more understanding of how to produce interventions that reduce these differences.
Where's the evidence base that this would change public health at a population level?
Yeah.
So you mean we need to consider rather the system level instead of only the individual level? Yes. We follow that approach also very much. So there is one more hand.
Yes, thank you. Katrine Weerdenburg, GGD, Zuid-Holland-Zuid. In response to that, I think that is the question between equality and equity. If you look at investing in the public system, investing mental health for all, and you're about to apply behavioral science for all, or are you just looking at specific groups and investing in vulnerable groups that really need to change? I think that was the point of what we're talking about right now, the choice.
Okay, so basically in relation to this statement, did you stand up or did you sit down?
I stood up.
You stood up, yeah. And you say, well, we need those interventions that target people who are in more vulnerable circumstances.
Well, no, I didn't really give an opinion about it.
Okay.
Yes, I think we need to invest in behavioral science to apply better mental health behavior. And we can do that by investing in specific groups, or we can make the choice, we keep it public and do it for all. But that's a question.
Yeah, okay. Any other responses to this? Yes, we have. Sorry, I'll get to you. Please say your name.
Yeah, my name is Marjolijn Slager from Avans University of Applied Sciences. I sat down as well because I don't think we need more information, because I think we need to speak with people, and we should use the experience of people who have other opinions and to work with them to instead of doing things for them, but working with them. So that's the reason I sat down. And so I don't think we need more knowledge, but I think we need more experience knowledge.
Thank you. Kia ora koutou. My name's Andrew Old. I'm the Deputy Director General for the Public Health Agency in New Zealand. Thank you for the opportunity to be here. I stood up and I just, so just reflecting on the previous couple of comments, thought I could use an example from New Zealand that might illustrate it. And I wonder also whether we're talking about the same thing when we talk about what using behavioural sciences might actually do. Or be about. So in our context, similar to many of yours, we've seen drop-offs in our trust of childhood immunisations as a result of mistrust, and COVID vaccinations are sort of spill over into that, and particularly in our ethnic or Indigenous Māori community. And so we've been using some behavioural insights work to try and understand why that is. So what are the beliefs, what are the behaviours, what are the reasons that people in particular communities are now choosing not to take up vaccination in the same way they were before, because we've tried using the things that used to work, throwing more money at it, getting people to go and visit their houses, using people from their own communities, and those things haven't worked in the same way that they have previously. So now taking a step back to say why, and then using that information to help us redesign and hopefully reconnect with some of those communities. Thanks.
Thank you.
The microphone, yes.
I'm Lorna Rennick from Public Health Scotland, and I was just remarking on something exactly the same, I suppose, and my example is another one that is about access to services. So where I think we apply this is in, say, for example, access to increase uptake of screening. And so it's a similar example, and we use that approach and look at, so for example, user engagement and lived experience, for example, in ethnic minorities around breast screening. what I was quite interested in really was more the system level approach to the BCI rather than the individual behaviour change, which we know that is proven not to be really that useful and effective in terms of population health gain. So that's, I think, why I stood up, but I probably would have stood up and sat down at the same time if that's allowed. So I think you did an individual hover, a middle hover, didn't you, at the last one? So, and I think partly it is about how we understand behaviour change as opposed to behavioural insights, behavioural change insights. So I don't want to get us into that as the lifestyle drift was coined. We don't want to just get into that encouraging people to, you have to give up smoking. It's more the environment around and the legislation around a smoking behaviour that is effective. But if there's system insights that help, then I would stand.
Yeah, thank you very much. Actually, the idea was to invite our speakers to the stage and open the discussion and the question round. So if you have any direct questions to the inputs, or you have general questions, statements, you're very welcome to raise your hand. And yeah, great. Yes, of course.
Can you hear me?
Yeah.
So I just wanted to say I really agreed with where this discussion ended. I think a lot of this has to do with how we understand behavioral science and whether that's a field of science that only focuses on individuals having to change or whether it has that broad focus. And I just wanted to say that's actually one of the reasons why we ended up calling our unit the Behavioral and Cultural Insights Unit, because we wanted to make it clear that we have that very broad understanding and we never only look at individual factors, but always the broad factors. And if there's time, I have just a very small example. Is there time?
Yeah.
Yeah?
Yes, of course.
So I've been working on vaccination behaviors for many years, and a few of you mentioned that as well. I was working in a country where there are a number of Roma communities, and traditionally they have a lower vaccination uptake, and we interviewed some of the service providers, and they all said, oh, it's because there's community resistance, and also they don't understand and they don't want to, and that's the reason. And so we did an observation study, and we observed high-performing facilities and low-performing facilities, but really serving the same types of communities. And what we were able to see was that the high-performing communities were really just following standard operating practice for a vaccination consultation. So they were asking, do you have any questions? They responded to the concerns that the parent had. They used pain mitigation techniques. They got informed consent. They really just followed the standard practice. And the facilities that had low uptake really sort of basically didn't follow that procedure and just said, oh, it's time for vaccination. And they said, it's time for... And then afterwards they were interviewed and asked why. And they had some, they weren't bad people, but they had some perceptions about the communities and the people they served that they didn't understand and they wouldn't understand anyway. And, you know, you don't want to get into a discussion with these people, things like that. And that was the main reason. So it had, the focus needed to be on the service provision and not on the individual. There was obviously a level of low health literacy, but the responsibility was actually on how the services were provided. And in this particular case, we wouldn't have been able to build on that if we hadn't done the studies. So it's just to say, when I stood up, it's because I think of it as a very broad thing where we look at all the different types of barriers, and we needed to do that study with the local stakeholders to build on that and find a way forward.
Yeah, thank you very much.
So you also mentioned that online the systems perspective is really important rather than the individual. Do you feel like reflecting on this from that angle?
Yeah. It works, right? Okay, good. Yes, I think so. Like one of the things that I didn't really mention in my presentation is becoming an increasingly important topic of discussion is that of institutional trust or sort of generalized trust, I suppose, right? And the way that works, theoretically at least, is, well, complicated but can be explained, which is if the entity that is in charge of determining which health behaviors are recommended is not trusted by you as an individual or by the members of the group that you consider yourself to be a part of, then you're unlikely to take part in those recommendations, right? If, say, the GGZ in the Netherlands is not trusted by a particular individual or a particular group of people, and they are perceived to be in charge of vaccinations, then of course it's very unlikely that someone will say, well, I guess I'll go get vaccinated by this institution that I do not trust, right? And so that in turn also fuels and is fueled by, right, inaccurate perceptions of what that institution is and does, but also more generalized kind of inaccurate perceptions with respect to the health behavior that you care about. So for instance, you might distrust public health authorities, and therefore when you see a piece of information online that says actually health authorities are trying to insert microchips into your vaccine to exert mind control, it might sound more plausible than if you have high trust in those authorities, which sounds like a tautology, right? It sounds like an obvious truth, but it's still such an important component of what we're looking at. And so with respect to the WHO, for instance, I think there's the WHO took a huge hit during COVID, right? Not necessarily because they did something badly wrong. It's just that in a time like this, there's almost nothing you can do to prevent a rise of distrust in the global entity that is perceived to be in charge of managing the pandemic, right? And so from my knowledge, at least, the WHO has not yet quite recovered from this, right? But it is key in so many different areas that trust is recovered and restored, because otherwise the implementation of all kinds of programs becomes incredibly difficult. So luckily the RIVM here is looking at this with the SocialVax program, for instance, which I think is very important. So that's a good thing. There's a lot of research being poured into it, but we're not quite there yet. Sorry, you seem like you want to chime in.
Yeah, please. Yeah.
Can I also pick up on this? So I think I agree with Katrine and also some of our colleagues in the audience that mentioned about the definition of behavioral science was we didn't really define the way when we ask good question to the audience. But I think many things are really true. Like for example, co-creation. Like when we work with local populations, we always try to do interviews and understand, and then try to be in their foot, and then really feel what needed and what is missing, and then we do interviews and then co-create all together, and that builds trust. Like Ron mentioned, the trust is very important. If you don't have trust from the authorities or people who are working together, then the intervention you create never works, never reach to end users. So that's why co-creation and trust is really key. And for that, behavioral science, if you see it narrow terms, maybe a little bit more like defining too much, but then understanding and then make the local population ownership of the intervention. This is always very important. And because every population has different reasons to not act. I have been working with disaster risk reduction in the different places. And then some areas very, not so safe for women to walk around in the night. And then, disaster happens. And then the earning warning system of the alarm goes. And then some population don't move, especially women doesn't leave the house. And then why is that? Because not only because they cannot walk outside, but also they find it scary to be in the shelter because they don't know about the safety of the shelter. And then the top authority probably provide all the shelters in the places in the village, but then no one is using it. Like this kind of thing, you need to find out why this is not working. And this is very important. So that's why trust co-creation is key for making proper intervention. Thank you.
Yeah, thank you very much. Are there any more questions? Yes, of course.
Thank you, Bert. I was wondering, during the COVID pandemic, the Dutch Institute of Public Health created the COVID behavioral science unit, and it was applauded by policymakers in also bringing advice on how to help policymakers to help the public. the problem was that there's no quick fix, right? So we had a lot of scientific evidence, but it was not like you could push one button and then create people to do what the policymakers would like. And in a way, I think that's one of the dangers also with behavioral insights and science, that policymakers tend to use it like cherry picking. So this is interesting, we use it, and we expect then that the outcome will be not based on the whole study, but on parts, and parts which are quite often, I think you mentioned it also, theoretically investigated. And I was wondering what your ideas are about that, and also in how we can prevent that science is actually again used in a way it should not be used, or even creating more distrust of science when policymakers use it with another point of view or another outcome idea.
Thank you. You want to start?
You want to go first? Yeah, I mean, I think it's for like politicians like to sell evidence-based policy, right? And how do you sell evidence-based policy? You say like, well, we hired a bunch of scientists, they told us to do this, we did it, and therefore it's evidence-based. And then when that inevitably leads to disappointing results, because human behavior is really tricky, and it's probably for the best that it's not that easy to influence, right? Overall, you might fuel sort of unnecessary skepticism. I agree with that. But here, it's not only kind of the behavioral science that we're then looking at, right? Like let's implement a nudge in the grocery store and expect that to lead to better purchases in terms of buying an apple instead of a bag of crisps. Sure, but we're also dealing with a variety of other relevant fields. For example, communication science, if you want to call it that, right? There are definitely guidelines on good versus bad communication. And so those are the kinds of evidence-based things that you can rely on that are sort of directly meaningfully helpful. For instance, when it comes to communicating uncertainty, right? You're in a pandemic, there's a lot of uncertainty to go around. And so the guidelines tend to say things like, okay, here's a list of things that you should say and things that you should not say. For instance, here's what we know. Here's what we do not know. Here's what I'm going to do to find out why it is we don't know that. And here's when I'm going to update you once I do know and what I'm going to say, right? Like those are sort of clear communication strategies that are very helpful and can simply be followed. And so, but that is sort of within that same realm of, I guess, behavioral insights, because after all, the notion that information influences behavior in a very general sense is not particularly controversial. Of course, that's true, right? But the way that it does and under which circumstances it does and which it doesn't, that is much more tenuous. And so that's where I think we need to exercise due care, if that makes sense.
So what you're raising was one of the main points raised in that interview study we did with our member states to understand what the barriers are for really advancing the use of these methodologies in health. So it is a key issue, and it's one that many people feel. And we did an evaluation actually of behavioral insights studies conducted during COVID, and it was the same thing. A lot of teams felt that they'd invested and done terrific work and had important insights, and then nobody really seemed to want to use them. So that was a clear challenge. I think a lot of this has to do with this still being a fairly immature field in public health, and we need to think about this as an integrated element into bigger work. So when we work with developing policies, or we work with developing our health services or health communications, as you say, it's really not about just, let's go over to these people and ask what it is. It's about considering all the different types of data that we need to consider. Social determinants, health systems related data, economic data, and then some behavioral and cultural facts and other data. And all of that together will then lead us to an answer, and sort of see this as an integrated thing and not as a separate thing over there. That's how I see it.
Thank you. So I think our time is up, unless there's something you would like to add to the last? No, I just want to give everybody equal opportunity to close up.
Then maybe just quickly to the point my colleagues mentioned. So I think the data evidence-based policy is very important, and so there are some mental health field. It's very difficult to gain enough data, and especially in the developing countries, it's very difficult to collect enough data to build evidence-based policy. So that's one thing. So we have been struggling with. So that this kind of things should be always considered to create a better policy, and it's need to be understood well. So that's a very small point.
Thank you very much. Okay, that was very lively discussion. Thank you so much. So we're going to wrap up this session on the sort of the behavioral sciences. I hadn't expected that statement would result in so much debate, but that's a good point. So there's enough also to discuss today after the session. And a lot seems to do with what do we consider to be behavioral sciences? Does that include this context? Does that include implementation science? So part of this is also in the definition, I think, of how we perceive that. But very valid points all over, and I give the floor back to you. Thank you.
Thank you. Fantastic. Thanks a lot to the moderators and the speakers for both sessions, actually. Really very insightful. Thanks a lot. And we are now moving to our final concluding session with some final reflections. And unfortunately, Bert van der Hoek, the CEO of the Trimbos-Institute, couldn't be here with us in person, but he recorded a video for us, which we will be able to see now. Yes.
As we bring our seminar to a close, I want to share a few observations and remarks. We've heard how the increased focus on mental health and the need to focus not just on individual, but also social and population level, actions are timely and crucial given the complex societal challenges about us. Mental health isn't just a topic, but it's a vital component of our well-being, affecting individuals, families, and communities across Europe. Today's discussions have underscored the importance of integrating mental health into all public health policies and creating healthy environments that promote mental health and well-being. We have also heard how important it is to make visible the gains and benefits of investing in mental health and well-being for other policy domains. And we have heard examples of countries, initiatives and projects in Europe doing this. It's imperative to collaborate with policymakers, people with lived experiences, professionals, community organizations and scientists to comprehensively address mental health. This week, we have European elections. We face important choices in what kind of society we want to live in. As Trimbos-Institute, we stand for a mentally healthy society in which everyone can participate to the best of their ability. People have control over their own life and feel connected to each other. I call on politicians, policymakers and decision makers to be aware of the importance of well-being, not just for the 20% of successful people, but for everyone. Especially in these times of staff shortages, we need everyone. We need all the capacity, talent and quality of people to maintain social facilities, to ensure sufficient support for people who cannot do it alone, and above all, sufficient opportunities for personal and social growth for everyone. Spend money on improving mental health and reducing health inequities are no costs in themselves. They are investments in a vital society. And this is necessary to grow towards a sustainable society, but it's also necessary to grow towards a sustainable economy. So let's hope that the awareness of the importance of mental health for everyone will grow, even as the willingness to invest in it. And that the results of the European elections give support to this and make this possible. Because everyone matters. Thank you.
Many thanks, Bert. We know that you are listening online, you are with us, and many thanks for your great messages and important messages as well. And we very much hope together with you. Now I'm delighted to invite Professor Arjan Bos, the head of the Center for Public Health Care and Society at RIVM, to share with us your reflections. And you've been listening attentively and making lots of notes, you already told me, so I'm very keen to hear what you can make out of it. Yeah.
Good afternoon. I think today we've had a very interesting seminar altogether. And the seminar focused both on mental health in the first part and more on the behavioral sciences in the second part. And it's interesting because I did my PhD at the Department of Health Promotion and I developed my career in the way of clinical psychology. So I think I'm an example of the integration of both fields. I think they should work together more, and at the RIVM we consider mental health also as a part of the broad health. I think it consists on both physical, social and mental aspects. The key question of today was, how can we ensure health and well-being for everyone? And that's where all our presenters have focused on. And in the beginning, we knew that mental health is going to get a lot of attention, and it's very complex. But then Laura Shields told us that we had different levels. So we had the individual level, but also the social level and the structural level. And one of the take-home messages is that the social and especially the structural level is very important. And we've seen that through all presentations that we cannot improve mental health if we don't look at the structural level. And in my field, I do a lot of research on mental illness stigma and on the impact of social stigma on mental health of individuals. And in my field, there's also increasingly attention for structural factors. And we call that then structural stigma. And one famous research in that field is about what policies in the United States, policies that protect the rights of LGBT people, how that can impact the mental health of transgender individuals. And in that research, they found that in those states in the United States where they didn't have laws to protect the rights of LGBT people, there were more suicide attempts among transgender individuals. So that illustrates how important it is also to look at the structural level, and that the structural level impacts also the individual level of people. So I think it's very good to know that the structural level is very important. What we also found today is that we need each other. We need all different disciplines to combat mental health problems. We have to do that all together. Not only psychologists tend to focus on individuals, but we need other people who also can influence policies, who can change laws. At all levels, we have to tackle that. Also, the social context of people is very important. We heard that today as well. Income is important. We can do support housing. If we have early life home visits, all those things that Laura didn't want to tell in the beginning, she did later on. It's important to do those things and also take care at that when you want to tackle mental health problems. Also, we looked at behavior today. And what I find key is that in several presentations, we heard that behaviors are critical for health equity, but that we also need tailored programs. So we really need to tailor those programs. And also from my background, I think it's very important to have theory and evidence-based interventions that are developed together with the target group. and that you don't only look at the individual level again, but also look at the environment, and that you have to do that from theory, and then all the knowledge you have, you use to make the best intervention possible. And I think if we do that, we can really also work to create the goal of today, and to ensure health and well-being for everyone. So yeah, those are, I think, key things that I heard. Maybe you heard other things, but these are things that I heard, and I think we should discuss all the things we heard now at the alcohol-free borrel. But before that, before I end up, I give the floor back, because then you can close the seminar. But thank you very much. I think it was a very good day, and I think the key message has produced a lot of interesting thoughts and reflections.
Many thanks. Actually, your reflections are very much corresponding with my reflections as well. Maybe a few takeaways from my side. Indeed, it's important to provide evidence-based advice to policymakers, and we heard that we also need to think about how to communicate them better. And also how to create political will for policymakers to also appreciate that this is an important area of work, and we need to really invest in this, and to convey that sense of urgency that we have seen in COVID, but we need to keep that going, that sense of urgency amidst all other important topics, of course. And indeed, as you were saying, it's very much the twofold approach that we have discussed here. On the one hand, we need to have the action on the ground to support people in targeted and tailored way, boosting health literacy, media literacy, using digital and social innovations, applying behavior culture insights. Particularly what I noted from you, Sanae, you had somewhere on your slide that people respond different to challenges, the flight, fight, freeze mode. So, hey, that's interesting. Because that's true indeed. And what does that tell us for our policies and measures if you think about these three issues? But at the same time, as we said before, we all appreciate it's really important to work on a systemic level, on the government level. The well-being economy, I think, is a very nice concept that demonstrates that health equity and well-being need to be at the center of policy making. It needs to be at the center of economic policy, of housing policy, of education policy, of environmental policy, climate change policy, and so on. And we need to develop our evidence and communicate about our evidence in such a way that we demonstrate these are the co-benefits for health, and shape new narratives that works with the newly elected politicians, for example, in the European Parliament. But we do need to do more than just acknowledging this. We really need to act on it. So your call on advocacy, I think, is important. We need to have capacities in our organizations to actually go to the policymakers in other sectors and do these things. The cost of inaction is big, as we know, and I think this is an important message for finance people. Quick fixes, we heard, doesn't work, but we need this robust and well-grounded strategies and implementation as well, as was said. I think the seminar also shown that that European cooperation is very promising, it's inspiring, you can learn a lot from each other. And also we need to make very good use of the international institutions. We have the WHO with their BCI framework, with the Mental Health Coalition. We heard from the OECD with their work on the well-being economy. We have the European Commission with the potential to legislate with their funding programs and their strategies. And then obviously European partnerships like EuroHealthNet, but there are also other European partnerships like Mental Health Europe. Claudia's not here anymore, but it is important to work together in order to also learn from each other and to find support from each other for the future to come. Yes, so we are coming to an end now, indeed, and I would like to thank all of the speakers for your fantastic input and the excellent co-moderators as well for the two sessions. I would like to thank RIVM very much and the Trimbos-Institute for co-organizing this event and for hosting also the meeting that we will have with EuroHealthNet in the coming 2 days. I would like to thank the Commission. The European Commission is co-funding this event as well. And my team at EuroHealthNet and the teams, Duke, for example, at RIVM and Trimbos, Laura. And at EuroHealthNet, we have David, we have Anne, who is not here with us today, but I know she's watching online, and Sylvia and Alba and Chris. And the colleagues in the office. Without them, it was not possible to have this event. And lastly, I would like to thank the participants online, being still with us. Thanks a lot for doing that. And to all of you, you have been a great audience, stepping up and sitting down and responding with your questions and comments. So thanks to you all. And we have a nice reception for all of you here. Can I just please ask you for the EuroHealthNet members to keep your badge, and for those of you leaving after reception, if you can drop your badge somewhere over there on the table, I suppose. Okay. Okay, thanks a lot. And yeah, thank you. This is it.